Jay.
Hello.
Yes, ma'am.
Hello. Good. Can I start?
Yes, ma'am. Yes, ma'am. 2 minutes, ma'am.
Hello.
2
अच्छा
minutes,
we
ma'am.
have to. Okay, we have started.
Nearly 7.
It start time to हो गया.
Welcome, ma'am. Over to you, ma'am.
Good evening, everybody, and welcome to the ICA webinar, which is held every week. And it's my pleasure today to be hosting the ICA webinar on pediatric anesthesia. You know, we get a lot of inputs from the students, and they actually tell us what are the webinars they are interested in. So many students told us that pediatric has not been covered for a long time. So we've taken this topic up, and I'm very pleased to tell you all that we have very eminent speakers. And of course, our chairpersons are very well known to all of us. They are pediatric anesthesiologists practicing in Delhi for so many years. To introduce the moderators, Dr. Usha Saha. She is, of course, a very, very senior director professor. She was the HOD and director professor in the Lady Harding Medical College and the Associated Pediatric Hospital. And she was also the HOD of the Delhi University. A very close friend of ours and a very, very senior. She was an examiner, and she still continues to be an examiner. Second one is, of course, my very dear colleague, Dr. Deepanjali Pant. She has done a lot of training in pediatric anesthesia from UK, and now she is practicing pediatric anesthesia in our hospital. She is a very capable anesthesiologist as well as a very good academician. At this juncture, I would also like to thank Mr. Rahul Choube, who is always helping us in our webinars, in the live streaming on the TV. And thank you very much, Dr. Rahul. And now with these few words, I'd like Usha, could you please start the webinar? Thank you. Usha? Deepa, is Usha there? Hello?
Yeah, ma'am, she is here, ma'am. So I think due to some technical issues, we are not able to hear Dr. Usha. So can I request Dr. Deepanjali Pant to take over?
Sure. Deepanjali? Hello?
Dr. Deepanjali, you are muted. Yeah.
No, I am here. I just wanted to tell you, Dr. Poonam has not got the connection link. That's what I was trying to give her.
Okay, I'll send again to her.
Yeah. You get to her.
Deepanjali?
Ma'am.
You could start the introduction of the first speaker, please.
Geeta, please share your screen. The first slide I would like to have.
Yes, ma'am. I'm just.
This is my pleasure to introduce my dear junior, Dr. Geeta Setia. She is an associate consultant in Sir Gangaram Hospital. She is a pediatric anesthesiologist with a pediatric fellowship. And she will be speaking on perioperative fluid therapy. What's the best fluid for the situations? Geeta, over to you.
Thank you, ma'am. Thank you, chairpersons. Good evening, everyone. So, perioperative fluid therapy in pediatric patients, what is the right choice? So why perioperative fluid replacement is crucial in this age group? It is to maintain an adequate intravascular volume to prevent the development of hyponatremia, hypochloremic acidosis, hyponatremia, and other electrolyte imbalances, which happens due to limited ability to compensate for volume access and volume loss in this age group. So there are many physiological considerations and developmental factors different. So in cardiovascular system, these patients have incomplete myocardial development, immature sympathetic innervation, which makes them sensitive to hypovolemia. In renal system, they have immature renal function at birth, decreased GFR. It's 25% of adult level at term, and whereas the adult levels are at age of age of 2 years. So up to 2 years, they have concentrating capacity urine 600 to adult make their kids with a limited capacity or volume depletion. Again, in their renal system, there is increased free water clearance. They excrete markedly dilute urine up to 50 millismol per liter kg versus 70 to 100 osmol per kg is in adult patients. They have low sodium reabsorption, decreased bicarbonate hydrogen exchange in their kidneys, increased urinary losses of potassium and chloride ions. In the liver, they have limited hepatic glycogen stores, which make them prone to develop hypoglycemia. The metabolic and fluid requirements physiologically differ in this age group because of increased metabolic rate, increased oxygen consumption, which is in neonates 6 to 9 ml per kg per minute as compared to adults of 3 ml per kg per minute. And also they have increased calorie requirement up to 120 kilocalories per kg per day. Increased fluid requirement in this age group is again because of greater body surface area to mass ratio. Other factors also include use of radiant warmers, having fever, critical illness, trauma, polytrauma, thinner skin, lack of keratinization of stratum corneum in premature neonates. All of this make them lose lots of insensible water. So there is a brief description about body fluid composition we all are aware of. Again, it differs in infants and children than as compared to adults. So their total body water is 75% in infants, 70% in children, whereas it is 55 to 60% in adult patients. ECF again 40% in infant and 30% in children as compared to 20% in adult patients. So how do we calculate the perioperative fluid replacement? So we grossly divide it into 4 types of replacements. One is the maintenance fluid replacement. Second, the replacement of estimated volume deficit due to the preoperative fasting hours. Third, the replacement of insensible losses or third space losses. Fourth, the replacement of ongoing surgical blood losses. So this is the brief summary. Maintenance fluid plus EFD plus insensible losses plus EBL, estimated blood loss. So we'll go with maintenance fluids. So maintenance fluid usually replace water and electrolytes lost under ordinary conditions in children. That is evaporative insensible water loss, urinary and stool losses, and the basic metabolic caloric requirement. Urinary losses are usually up to 280 to 300 milliosmol per kg of water with specific gravity of 1.008 to 1.015. This is usually 2/3 of the total maintenance fluid. So how to decide the maintenance fluid therapy? Grossly, it's the age group is divided into 2 age groups. Again, newborn, term, and older children. In newborns, on day 1, 50 to 60 ml per kg per day, we can give dextrose 5 to 10% in water. On day 2, we can give 100 ml per kg per day, dextrose 5 to 10% in half saline. Age more than day 7, 100 to 150 ml per kg per day, dextrose 5 to 10% in 1/4 saline. In older children, we go by OH method, or we call it 4-to-1 rule, or holiday cigar method. So the 4-to-1 rule implies here as per the body weight of the patient. So up to the weight of 0 to 10 kgs, we give 4 ml per kg per hour. For every additional 10 kgs, we go additionally 2 ml per kg per hour and then 1 ml per kg per hour. Holiday and cigar method, again based on body weight. 0 to 10 kg body weight child will receive 100 ml per kg per day. 10 to 20 kgs will be receiving 1000 plus 50 ml per kg per day, and above 20 kgs 1500 plus 20 ml per kg per day. So how do we replace preoperative fasting fluid deficit? So if the child is not dehydrated and it's a healthy child for a short procedure, number of fasting hours is multiplied by the maintenance fluid. And the volume we receive from it, we infuse half of it during the first hour of surgery, 1/4 of this on the second hour, and the other 1/4 during the third hour of surgery. This is how we replace preoperative fluid deficit. And if the child is dehydrated, we need to assess the degree of dehydration. So dehydration in children could be of mild degree, whereas 1 to 5% of loss of total body water. Child had symptoms of vomiting, diarrhea, decreased urine output. Moderate degree, 6 to 10% of loss of total body water. Skin turgor, sunken eyes and fontanelles, weight loss, dry mucous membranes, lethargic child. Severe degree of dehydration, in which cardiovascular instability takes place. Hypotension, mottled skin, tachycardia, anuria, and sensory changes. 20% loss of total body water can lead to coma and shock. Then comes the ASA fasting guidelines to assess the preoperative fluid deficit. So the fasting guidelines for children has been lately updated, which is clear liquids we can give up to 2 hours before the surgery. Breast milk is allowed up to 4 hours before surgery. Infant formula, neonates for 4 hours. Infants, 6 hours. Normal milk, 6 hours. And for solids, it's 8 hours. What is clear liquid? Clear liquid means liquids which are see-through. So that can be water, juices without pulp, carbonated beverages, clear tea, black coffee. Type of liquid ingested is way more important than the volume. In infants less than 5 months, although more than 10 ml per kg should not be given. Children and adults, 15 ml per kg. Breast milk. Breast milk is not a clear liquid. It contains milk solids, although it clears from the stomach more quickly than the other milk. Gastric fluid volume and pH are independent of the duration fast beyond 2 hours. So main determinant here will be endogenous gastric secretions. Still, the pre-op fast does not guarantee an empty stomach. Timing of last fluid ingestion has little relation to the volume of gastric contents at induction. But pre-op fasting reduces the risk of pulmonary aspirations, and offering clear liquids up to 2 hours before induction again helps, reduces hunger and irritability in children, preserves hydration, and decreases the risk of hypoglycemia. What are the daily electrolyte requirements? Daily electrolyte requirements in children for sodium is 2 to 3 milligram per kg per day till the age of day 3. Potassium 1 to 2 milligram per kg per day till the age of day 4. Chloride 2 to 3 milligram per kg per day, and calcium up to day 1, 20 to 100 milligram per kg per day. And then comes the glucose requirement. So is intraoperative glucose necessary? So for so many years, we have been using dextrose intraoperatively for children up to quite an older age. But lately, the controversies and dilemmas have been reviewed, and there are so many reviewed articles and reviewed publication has shown that we should limit the use of glucose in older children. So basic requirement of glucose in term and preterm infants is 5 to 6 milligram per kg per minute. So our goal is to maintain normoglycemia, which is 40 to 120 milligram per deciliter. Dextrose 5% in water, usually we give 100 ml per kg per day in less than 1 kg of infants. So we have limited the dextrose use up to the age of 48 hours. Beyond that, we usually give 1 to 2.5% of dextrose only in longer procedures. The effect of intraoperative glucose administrations had been intraop hyperglycemia, hyperosmolality, osmotic diuresis, and it worsens again neurologic outcome during cerebral ischemia. So dextrose, if given, it is to be given as dextrose 5 to 10% in water or N/2 solutions, recommended in newborns up to the age of 48 hours. In older kids, dextrose 1 to 2.5% to be added in the maintenance dose or to be given in N/2 solutions, in case we are not using balanced salt solution. So choice of IV fluids in perioperative fluid replacement. So there are 3 types of major IV fluids. Balanced salt solutions. These are most appropriate IV fluids these days, which are Cabilite, Plasmalite, Sterofundin, Also, we can consider dextrose 1 to 2.5% in N/2. But it is usually these are slightly expensive. Then comes isotonic crystalloids. Generally, it is the most available IV fluid for pre-op and intra-op deficits throughout the country. Ringer's lactate, normal saline, Hartmann solution. Then there are hypotonic fluids, which is dextrose 5%, dextrose 10%, N/4, which are rarely used these days, again, due to the risk of hyponatremia. So balanced salt solutions are the choice of IV fluids in this age group due to its electrolyte, glucose and lactate content more close to the physiological range. Ringer's lactate is reasonable for maintenance fluid for short procedures, daycare surgeries, less expensive, of course, than other balanced salt solutions, provide sodium and potassium, but should be avoided if infused with blood. Normal saline has a higher sodium content, so should be considered only in patients and sick children with high risk of cerebral edema. Prolonged infusions can lead to hyponatremia, hyperkalemia, and metabolic acidosis. A brief difference between different kind of IV fluids. After crystalloids, we have colloids. So composition of colloid solutions. In colloids, we can use 5% albumin, Hespan, Voluben, Hexten, and Volulite. Albumin usually is available in 25% and 5% solutions, also in 20%. It is pooled from human donors, no ABU testing or blood filters required for that. It obviously is a very expensive drug and always in short supply at smaller centers. Also, again, there is a dilemma about albumin. Is it risk-free in pediatric age group? Well, there was a case in New Zealand where albumin has been related to Creutzfeldt disease or Bryant disease with long incubation period, more than 5 to 10 years. So usually we limit the use of albumin to critically ill patients in ICU, pediatric patients in ICU, not to be used for intra fluid replacement or intra fluid losses. Then comes the replacement of ongoing losses. So ongoing losses could be blood loss, urine output, insensible losses, and drainages from various sites. Then the third space loss. Third space loss is increased in cases of trauma, burns, peritonitis, and upper GI drainage. Replacement of ongoing losses can be calculated grossly trauma. For example, for a minimal incision, we calculate it as a 3 to 5 ml per kg per hour replacement of the fluid. Moderate incision, we take it as 5 to 10 ml per kg per hour of additional fluid. And for larger incisions or with bowel exposures, we take as 8 to 20 ml per kg per hour of additional fluid. So estimated blood loss replacement. So the well-known formula to replace the blood loss is the ratio, how we give crystalloid, colloids, and blood products for that. Crystalloids we give in a 3:1 ratio, like 3 ml of blood for 3 ml of crystalloid for each 1 ml of blood loss. Colloid solution 1:1 ratio, 1 ml for each 1 ml blood lost, and blood products again 1:1 ratio, 1 ml for each 1 ml blood lost. The triggers for blood transfusion. So for the triggers for blood transfusion in pediatric patients is estimated blood volume, preoperative hematocrit, and coexisting illnesses. Estimated blood volume in premature neonates usually is 95 to 100 ml per kg. In full-term neonates, 85 to 90 ml per kg. In infants, 80 ml per kg, whereas in adults, 75 ml per kg in males and 65 ml per kg in females. So the normal and acceptable ranges of hematocrit in prematures, newborn, 3 months of age, and 1 year and 6 years of child. So normal hematocrit is hematocrit within 2 standard deviations for age, and where can blood transfusion. hematocrit patient's hematocrit minus target hematocrit divided by patient's hematocrit into estimated blood volume. How we replace blood products in pediatric patients. PRBCs can be given as 10 ml per kg, and it will increase the hemoglobin by 3 gram per deciliter and hematocrit by 10%, whereas in adults, 1 unit increases the hemoglobin by 1 gram and hematocrit by 2 to 3%. Platelets and FFPs are given as 10 to 15 ml per kg and given when estimated blood loss is more than 1 to 2 times the patient's blood volume. Cryoprecipitate is used as 1 unit for every 10 kgs. So to conclude, for brief procedures, short procedures like myringotomy, PET scan, MRI, CT scan, or biopsies, replacement may not be necessary. Short procedures, 1 to 2 hour procedures, IV placement can be done after inhalation and induction, and fluid should be replaced by using 10 to 20 ml per kg plus estimated blood loss in first hour. Longer and complex procedures, we use 4-to-1 rule, acute intravascular loss replacement, and the ongoing blood loss replacement with balanced salt solutions. So meticulous fluid management is required in pediatric patients due to limited margin of error, and liberalization of fasting guidelines compatible with safety limits the preoperative fluid deficit. Crystalloids and balanced salt solutions are the first choice to restore intravascular volume. Limit the use of glucose-containing solutions for patients at high risk for hyperglycemia and beyond the age of 48 hours. This potential for further blood loss, 25% decrease in estimated blood volume. These are my references. Thank you.
Thank you, Geeta. It was very nicely covered, the whole spectrum of fluid therapy. I'm sure there will be questions and we'll come to you at the end. Now we are going forward to the next topic.
Deepanjali, shall I introduce?
Yeah, ma'am, please.
So the next topic is another important topic in pediatric anesthesia, which is TIVA in children. And it is being presented by Dr Anju Bhalotra. She is an MD anesthetist from AIMS, followed by senior residency also from AIMS. Then after a short stint in UK, she came back to India and now she is a director professor at Maulana Azad Medical College. She has a special interest in pediatric anesthesia and airway management. She's a certified ACLS trainer and she has several publications in international and national journals. And she is on board on several journals. She has trained a lot of anesthetists and she's a member of DNB board also. Dr. Anju, please.
Thank you, ma'am. Thank you for the welcome. My topic for today is TIVA in children. Now, TIVA stands for Total Intravenous Anesthesia, and it is defined as the maintenance of general anesthesia by the intravenous infusion of drugs. Now, recently, due to the understanding of the favorable pharmacokinetic and pharmacodynamic properties of propofol and the availability of short-acting opioids, TIVA has started to gain popularity amongst the pediatric anesthesiologists. Now, what are the benefits that TIVA gives to children? It leads to a smooth, pleasant induction of anesthesia. There is a reduced airway reactivity, laryngospasm, and bronchospasm. There's a reduction in the post-operative nausea and vomiting. There is a reduction in the emergence delirium. And this translates into an increased patient comfort and parental satisfaction post-operatively. It also helps in avoiding environmental pollution. But there are still some concerns regarding the use of TIVA in children, and many of us think about it in this way. When we think of propofol, we think immediately propofol infusion syndrome. Now, what is propofol infusion syndrome? When we give a large amount of propofol, the lipid load can interfere with the complexes in the electron transport chain and interfere with mitochondrial energy production. This can lead to rhabdomyolysis, acidemia, and multi-organ failure. However, fortunately, this is a very rare, but it is potentially fatal, and this can recover if the child is monitored and the infusion is stopped in time. Now, the risk factors for propofol infusion are infusion of propofol at a rate of more than 4 milligram per kg per hour for more than 48 hours, children with critical illness, children with a low sugar intake and the co-administration of catecholamines and steroids, children with underlying metabolic disorders. So luckily for us, this is very, very rare under anesthesia and is usually encountered in children who are receiving TIVA in the ICU. The other concern that comes to mind amongst pediatric anesthesiologists is, will my child become aware? I can't monitor the plasma levels of propofol. Supposing the propofol pump malfunctions and the drug is not delivered. Supposing my IV cannula gets tissued and I cannot deliver the drug, then will the child become aware? However, this has also been studied. A recent project in the UK, the NAP5, showed that the incidence of awareness following TIVA in children is very low. 2.18 million GAs were studied, and there were 141 cases of accidental awareness under general anesthesia, of which only 8 were in children, and of those 8, only 1 was in a child. One involved TIVA. The other problems that come to mind when we think of giving TIVA are the difficulty in securing IV access in small children, the pain on injection of when we give propofol, the great pharmacokinetic and pharmacodynamic inter-individual variability in the disposition of drugs in neonates and small children, the requirement for specialized equipments, and the cost of the disposables like infusion lines, etc., and the environmental effects of plastic wastes which are generated. Volatile anesthetics are unavailable as in remote anesthesia or patient transfers. When volatile agents are contraindicated, or when delivery of inhalation agents is not in children who are at a risk of developing malignant hyperpyrexia, in children with risk of rhabdomyolysis and hyperkalemia, and when neurophysiological monitoring is required for spinal surgeries. TIVA may be especially beneficial in surgery which carry a high risk of postoperative nausea, vomiting, or when there's a history of severe postoperative nausea, vomiting, in children with upper respiratory tract infections or reactive airways, children who have a fear of face masks, in children with a high risk of emergence delirium or a past history of emergence delirium, airway and ENT surgery in order to reduce airway-related complications like laryngospasm or bronchospasm, which TIVA may be optional as trainee teaching and to maintain skills in the use of TIVA. So we should do TIVA on and off so that when we really need it, we can do it. Now, what are pharmacokinetics? Pharmacokinetics describes the relationship between the drug dose and the drug concentration in the plasma or at the drug site, effect site over time. Now, the pharmacokinetic behavior of most of the anesthetic drugs used for TIVA can be predicted with a 3-compartment model. Now, when a drug is administered in TIVA, the drug enters the central compartment V1. From there, over time, the drug is distributed to the rapidly equilibrating compartment V2, which is highly perfused organs, and the slowly equilibrating compartment V3, which is composed of the poorly perfused organs. And these lead to a decrease in the plasma concentration of the drug. It is from the central compartment that the drug is eliminated and metabolized, and it is from the central compartment that the drug goes and acts on the effect site, which in the case of anesthesia drugs is the brain. So when you give a bolus of any drug, it reaches a high plasma concentration, as you can see, and then there is a rapid decline due to redistribution and then due to elimination and clearance. So down. If you don't give a bolus and we directly start an infusion, the rate of rise of the drug to the therapeutic levels is going to be very, very slow. It takes almost 5 half-lives. So, and this is what has been called the BET or the BET infusion scheme for TIVA, the bolus elimination transfer scheme. In this, a bolus of drug is given first to fill the central compartment and to reach therapeutic drug levels, and then a maintenance infusion is given in order to replace the drug which is lost by elimination and by transfer to the peripheral compartments, which I described, B2 and B3. Now, that was just a brief overview of pharmacokinetics, and when we talk about children, we must understand that they have a larger volume of a central compartment V1, so they require a larger propofol bolus. They require larger initial infusion rates. They also have larger volumes of the peripheral compartments, which I described as V2 and V3. So they need larger initial infusion rates, but they have a slower recovery because redistribution occurs from the peripheral compartments back into the V1 compartment. So they have a longer context-sensitive half-life, and they might take a longer time to recover. They also have higher clearance rates, so for a prolonged surgery, they will require higher maintenance infusions. But this is not the same in all of the pediatric age group. In neonates, the clearance rates are lower because the organs are not fully mature. So neonate children, the metabolism may be deranged or slower, and there may be a marked pharmacokinetic variation. So when we want to, it can be understood in which a single drug can be given, a short procedure done, or intermittent boluses of a single drug or a combination of drugs can be given, or a fixed rate infusion can be given using an IV drip set or a syringe infusion pump, or we can use infusions which are based on a manual algorithm and which are more scientific. The other way of giving TIVA is by use of a target-controlled infusion. And another third way of giving TIVA is by closed loop administration. In the closed loop administration, the drug infusion is titrated against a measurable feedback signal, which may be BIS, BP, heart rate, and this completes the loop. So it's an automated delivery of drug depending upon a feedback signal. So it forms a closed loop. Now, we all are familiar with the manual infusion regime for propofol. The Roberts 10-8-6 regime is used extensively in adults. In this, the loading dose of 1 milligram per kg propofol is given, followed by 10 milligram per kg per hour for 10 minutes, 8 milligram per kg per hour for 10 minutes of propofol of around 3 to 4 microgram per ml, which is adequate for most surgical procedures. However, as you can see in the red line or the brick colored line, it is far below the therapeutic levels, below 2. And this protocol in children results in subtherapeutic plasma levels of propofol, and children have been found to require almost 2 times the initial doses of propofol because of the large compartment sizes. 2 popular pediatric infusions, Stewart regime, which is used in children aged less than 3 years. In the McFarlane manual infusion scheme, this targets a plasma propofol concentration of 3 microgram per ml and is used in children of 3 to 11 years. As you can see here, the induction dose, the bolus dose is larger. It's around 2.5 milligram per kg. And then sequentially, the infusion is decreased over a period of 4 hours from 15 to 13 to 11, 10, and then maintained at 9 milligram per kg per hour. The Stewart regime is used for children less than or equal to 3 years. In this, as you can see, the induction dose is much larger because the smaller babies have an even larger extracellular fellow ECF volume as described in the previous talk. So the induction dose is much larger, and even the initial boluses infusion rates are very high. So as you can, adults might result in significant hypotension and bradycardia. So this should be taken very carefully. And when these schemes are followed, clinical titration must be followed hand in hand. Now, the target controlled infusion is another automated form of delivering TIVA. In this system, a controlled infusion is delivered in order to achieve a user-defined target drug concentration in the plasma or the effect site. In the pediatric population, pharmacokinetic models only use plasma targeting. In the TCI system, the system is supplied with preloaded and activated pharmacokinetic parameters for propofol, remifentanil, etc., to maintain the selected target drug concentration which has been selected by the user or yourself. So the TCI system consists of an infusion pump which delivers a bolus and the subsequent infusion rates. They have microprocessors with the pharmacokinetic software in them. They have alarm systems, and there is a user interface here where you can select the drug that you are using in TIVA, which is a pharmacokinetic model that you are using in this TIVA, and what are the patient's body weight, age, sex, height. They have different parameters which have to be entered, and what target plasma concentration have you set or do you desire. Now, for pharmacokinetic models in children, only a few are available. The 2 widely available and validated pediatric pharmacokinetic models are the Kataria model for children of ages 3 to 16 years weighing 15 to 61 kilos, and the P-diffuser model, which is for children aged 1 to 16 years and weighing 5 to 61 kilos. For children who are weighing more than 61 kilos, a MARSH adult model may be used. And there are several models also under evaluation for children like the SHORT, the Shuttler, and the Elevale general purpose models. The pharmacokinetic model, another one, is available for remifentanil. These are the only pediatric TCI models which are available. In remifentanil, the Minto model is available for children who are aged more than 12 years with a weight of more than 30 kgs and a height of more than 1.3 meters. There are no pediatric smaller models for this. We must use various adjuncts along with it in order to improve the surgical conditions, to reduce the hemodynamic response to surgical stimulus, to lower the propofol target concentration, hence reduce the side effects of propofol like bradycardia and hypotension. The common adjuncts that are using it is an ultra-fast acting opioid with a very short context, insensitive half-life. I'm saying context insensitive because the half-life is independent of the duration of the infusion. So as soon as you stop the infusion, after whatever time, the child will wake up in 3 to 4 minutes. It may reduce the propofol requirements by up to 50%. For smaller children, there is no TCI model and manual infusions can be used. And the co-administration of propofol and remifentanil by TCI is a form of ideal TIVA. Other agents that can be used are ketamine. We all know the advantages of ketamine. It can be used as a single agent or it can be used along with propofol as an adjunct. There's a wide range of infusion rates depending upon what you are combining it with. It interferes with process EEG or BIS monitoring. That is to be remembered. Ketofol is a mixture of ketamine and propofol and has been used widely in emergency department for short procedures. Another agent which is gaining popularity is dexmedetomidine. You're all familiar with that. Dexmed has a very long context-sensitive half-life. It should be terminated well in advance if you're using it as an adjunct to propofol. Other opioids can be used like fentanyl and alfentanil. Then neuromuscular blocking drugs can be used in order to improve the surgical conditions, but they do not reduce the propofol requirements. And there is a risk of awareness because you paralyze a child, and if your TIVA is not adequate, the child might become aware. So you must use processed EEG or BIS when you're using a neuromuscular blocking drug in TIVA. Other drugs that have been used are midazolam, clonidine, and a peripheral nerve block or a neuraxial technique or regional block is very, very useful if given along with TIVA in order to reduce the propofol requirements. So when you're conducting a TIVA, you must check the drugs, the programming of the pump, the infusion sets, etc. should be checked. And the next question that comes to mind in the child is, how will I establish IV access in this child? Will I be able to secure my IV access before induction? Now that depends upon the age of the child, the indication for the TIVA, whether the child is likely to be cooperative, is the IV access difficult, and are there any comorbidities related to the airway or a cardiorespiratory? If you decide that you can try to secure an IV access, you can use various non-pharmacological and pharmacological strategies in order to facilitate IV access, like mentioned here. You're all familiar with this. The next hurdle that comes in children is you establish an IV access and now you're worried about pain when you give propofol to this child. So choose a large vein. If you're planning TIVA, choose a large vein, or even antituberal vein can be chosen. Lignocaine, opioids, ketamine, along with venous occlusion. And you can use lignocaine, propofol admixture can be used. If an IV line cannot be secured, then what do we do? Supposing we want to do a TIVA and we cannot secure an IV line, it is quite appropriate to obtain IV access after inhalation induction and then switch over to TIVA. Now, this will be highly unsuitable if the volatiles are completely contraindicated, like a child who's at risk for malignant hyperpyrexia. Obviously, this cannot be done. But it can be done if there's no absolute contraindication to TIVA. And then you can transition to TIVA. And during this transition, you must be very careful to prevent any under or overdosing. Now, once your IV line is in place and you are ready to go with the TIVA, you must the infusion is patent and viable. So the IV cannula should be kept visible at all times. An anti-reflux valve should be used. A multi-lumen extension set should be used if possible. There should be a minimal dead space volume, and the dead space must be flushed at the end of the case. You must check that the equipment is functioning properly. All the pumps are programmed and functioning properly. The correct drug in the correct pump and the correct drug concentration is being used. And pressure should be set on pumps in case the IV should extravasate. We should also check that the drug is going by seeing the effect of the TIVA. We can do processed EEG or BIS monitoring to see that the child is remaining anesthetized, monitoring of vitals, and clinical monitoring of patient responses, any patient movement, etc. So during the clinical conduct of TIVA, during induction, you can give an intravenous propofol bolus, which can be either manual or given by a variable rate infusion or by a TCI pump to target a plasma drug concentration of 4 to 6 micrograms per ml. In case intravenous line is not possible, you can do inhalation induction and then switch over to an IV access and then give a lesser bolus of propofol and a lower target plasma concentration as the inhalation agent concentrations decrease in the blood. At the same time, you can assess the clinical response and use a BIS monitoring and titrate the effect of the intravenous drugs accordingly. Now, how do you secure the airway? The airway can be secured with an endotracheal tube or a supraglottic airway device. You can give a neuromuscular blocking agent if you want once the child has gone to sleep. And the target plasma remifentanil concentration of 2.2 to 3 nanogram per ml and the target plasma propofol concentration of 3 to 4 microgram per ml has been found to obtain the intubation response. During the maintenance of anesthesia, the propofol target can be reduced to around 4 to 6 micrograms per ml. If a regional block or adjunctive drug is given, you can reduce it further to 4 microgram per ml. And if both are given, if either is given, then you reduce. And if both a block and an adjunctive agent like remifentanil are given, the propofol can be reduced to as low as 2.5 to 4 microgram per ml, and thus that decreases the side effects of propofol. The remifentanil targets have been described in the literature. If the child is spontaneously breathing, you have to keep a lower target. If the child is for a major surgery, you can keep a larger target. But remember that there is a great inter-individual variability in the response of the children to all these drugs. And the drug plasma concentration required will depend upon the ASA status of the child, the age of the child, whether it's a obese child, large child, small child, the co-administration of other adjunctive drugs. the degree of the surgical stimulus and gender, ethnic, and racial differences will also play a role. Hence, all infusions must be titrated to clinical signs of depth of anesthesia, monitoring of vital signs, and processed EEG. So monitoring under TIVA, as I've already told you, vitals must be monitored, clinical monitoring must be done, and effect size monitoring is done using processed EEG or BIS monitoring. The target value, as we know now in children, remains the same as for adults. We should aim for a BIS value of 40 to 60. BIS must be used in all children more than 1 year, and whenever we're using neuromuscular blocking drugs, BIS must be used. There are certain problems with using a processed EEG. All the algorithms that are available right now are based on adult EEG data. It is unreliable in children of less than 1 year of age. There might be latency or electrical interference. Normal patterns may be observed in children with developmental delay, like cerebral palsy. We find the BIS values are very low in these children, and their anesthetic requirements are also very low. But the use of processed EEG has definite advantages. It is very important to guide the TCI or the manual infusion and guide the depth of anesthesia. And it also serves as a disconnection monitor. In case your IV line gets dislodged, then the BIS values will start rising, and then you know that something has gone wrong. Then during recovery, children take longer to awaken than adults due to the larger size of the peripheral compartments. There's an increase in the context-sensitive half time, so when the infusion of the drugs is stopped, the drug diffuses back into the V1 compartment from the V2 and V3 compartment and takes a longer time to wear off. Most children awake at an estimated plasma concentration of propofol of 1.2 to 1.8 microgram per ml. If one is using remifentanil, we must give long-acting analgesic drugs like morphine before, at least 40 minutes before stopping remifentanil, because it will lead to hyperalgesia and acute opioid intolerance and severe pain because remifentanil wears off so fast. So to avoid a delayed recovery in children, you must reduce the propofol infusion rates early. You must try to use regional and peripheral nerve blocks wherever possible so that you can reduce your doses of propofol. Use adjuvant drugs to again reduce the doses of propofol, and use processed EEG monitoring. Now in the future, TIVA is likely to supersede inhalation anesthesia and pediatric anesthesia practice. It has so many advantages. Point of care propofol assays using either breath or plasma analysis are being investigated. Specific neonatal algorithms for processed EEG anesthesia depth monitors are also being developed. And the ultimate goal of TIVA will be a closed-loop controlled intravenous drug delivery, like the CLADS or the closed-loop anesthesia delivery systems, or the automated total intravenous anesthesia, TIVA, which will be the future of intravenous anesthesia. So we must remember that TIVA with propofol in children has distinct advantages. All anesthetists should be aware of the indications and the contraindications for propofol-based TIVA in children, and should also be aware of the pharmacokinetic and pharmacodynamic differences between adults and children. As in adults, standard safe TIVA practices for ensuring appropriate drug delivery to the patients must be ensured. And for further reading, you can read the guidelines for safe practice of total intravenous anesthesia at this link. Thank you very much. Thank you.
Thank you, Dr. Anju. You have really very well summarized the importance of TIVA, and none of us can deny the importance of TIVA in children. Because to my mind, one is avoiding the use of inhalation agents which are toxic to the developing in the smaller children, and like the other advantages you've said. And we can avoid invasive intubation. We can use LMAs and supraglottic devices. I think there'll be a lot of questions which will come at the end of the session. So we move on to the next topic now. Dr. Deepanjali.
Yes, ma'am. The next topic is pediatric airway evaluation and management. All of us know it becomes a nightmare when it comes unanticipated. This topic will be deliberated by Dr. Poonam Motiani, who is an additional professor pediatric anesthesia in Postgraduate Institute of Child Health, Noida. She has a lot of achievements on her account. She has initiated pediatric anesthesia services in this hospital in December 2015. And she has initiated fellowship, IPA fellowship initiated in February 2020. And she is a chairman, Oxygen Monitoring Committee during second wave COVID-19. She was the organizing chairperson of RAPACA in 2017. and organizing secretary of ultrasound guided nerve blocks in pediatrics. She has lot many publications, 28 index publications, 14 chapters in books, and attended more than 90 talks and sessions, chaired, delivered talks and chaired sessions. So she is the best person to talk about this topic. Over to Poonam, please.
Thank you, ma'am, for that introduction. At the outset, I would like to thank the organizers, Professor Jayshree Sood and Dr. Deepanjali Pant, for inviting me to talk at this very important webinar. And today I'll be talking about pediatric airway evaluation of management. And these I'll be covering it under these headings: magnitude of the problem, anatomical and physiological aspects of the pediatric airway and their implications, evaluation of the airway, challenges in the management using commonly available resources and locally adapted algorithms. Now, coming to the magnitude of the problem, in the year 2000, Jeffrey Murray et al. Published a paper in which they looked at the factors which were responsible for anesthesia-related cardiac arrest in children. They identified majority, the causes, 20% of the causes were attributed to respiratory events which were related to inadequate oxygenation and ventilation. Subsequently, in the year 2007, N. Jimenez et al. Also published a paper in which they identified airway and respiratory complications to be the major causes of the pediatric anesthesia liability claims. And they observed that these occurred frequently in healthy children, and they concluded that a failure to perform an adequate evaluation of the airway led to catastrophic outcome. So we all agree that the ultimate goal of mastering the pediatric airway is to ensure adequate oxygenation and ventilation, and proficiency in airway management is the key element in the safe conduct of pediatric anesthesia. Now, coming to the anatomical and the physiological aspects of the pediatric airway, which are unique, children, particularly neonates and small children, infants, have a proportionately larger head. They have a prominent occiput and a short neck. This predisposes them to airway obstruction during anesthesia. To circumvent this problem, a folded towel can be placed as a shoulder roll under the shoulders, and this helps to slightly extend the head and move it away from the chest and relieves the obstruction. This also helps to align the oral, the pharyngeal, and the laryngeal axis and improves the glottic exposure as is required for tracheal intubation. Further, children, particularly till the age of 5 months, are obligate nasal breathers. So any secretions, nasal secretions, or the presence of a nasogastric tube can disturb the pattern of breathing. Children also have a tongue which is larger in size as compared, proportionately larger in size, and it is difficult to manipulate. So the use of a straight blade for laryngoscopy is preferred. Preschool children in the age of 4 to 7 years have prominent adenoids and tonsils. They may have prominent adenoid and tonsils, which will itself contribute to difficult mass ventilation. Loss of upper airway space, excuse me, as occurs because of all these conditions in children, makes the laryngoscopy more difficult and endotracheal intubation more challenging in children. Coming to the epiglottis in neonates is higher, it's floppy, it's longer, it's narrow, and it's omega shaped, and it is angled away from the axis of the trachea. Because of these, again, a straight blade laryngoscope is preferred, wherein the blade of the laryngoscope goes below the epiglottis and directly lifts the epiglottis so as to expose the vocal cords. Also, the larynx is at a higher level in neonates as compared to adults. All these again contribute to making endotracheal intubation more challenging. The trachea in children, particularly in neonates, it's very small. It's about 4 centimeters in length. And the implications of this are that there can be endobronchial intubation or accidental extubation can occur. Also, may I request everyone to mute their mics? coming to the main stem bronchi. May I request everyone to kindly mute their mics? The main stem bronchi are equally angled. Therefore, if at all as they regurgitate, aspiration can occur on either side. This is in contrast to adults, where it would be more common on the right side. Coming to the shape of the larynx. The larynx, as we have all been conventionally taught, it is supposed to be funnel shaped in infants, with the apex of the cone lying at the cricoid cartilage. This is in contrast to the more cylindrical shape of the larynx, which occurs in adults. And these beliefs are all secondary to this report, which appeared in Anesthesiology in 1951. And based on these reports, uncuffed tubes have been advocated and preferred in children under the age of 6 years so as to avoid trauma due to cuff inflation. These authors believe that cricoid ring was the narrowest portion of the airway, and this is how we have been taught over the years. Subsequently, this has been questioned, and now following MRI studies and bronchoscopic studies, it has now been proven that the cross-sectional area of the cricoid is much larger than that of the glottis. And the glottis, the AP diameter is more than the lateral diameter. And the narrowest portion in an infant's airway or a neonate's airway is the glottis or the subglottic area. Therefore, now it has been postulated that cuffed endotracheal tubes, which have a low pressure, a high volume cuff, will seal the airway at the upper trachea, and they will produce a complete seal with low cuff pressure of less than 15 centimeters of water without any increase in airway complications. Uncuffed tubes have the advantage that a larger internal diameter tube can be used. They offer a lower resistance. However, if the leak is excessive, then there'll be suboptimal ventilation and there'll be a poor control of end-tidal carbon dioxide concentration. Also, it will lead to an increased aspiration risk and may call for a tube change. If the leak is large, then it may contribute to the OT atmospheric pollution and also have economic implications in the form of increased consumption of anesthetic gases. Cuffed endotracheal tubes, on the other hand, offer a minimum air leak, an accurate control of the PaCO2, a lower exchange rate, cause lower OT pollution, but they require diligent cuff pressure monitoring. The pressure should always be maintained less than 20 to 25 centimeters of water. An ideally placed cuff tube should have a short cylindrical cuff, which is placed near the tracheal tube tip. The cuff placement should be in the trachea and not in the pressure-sensitive larynx. There should be anatomically based depth mark helping in the correct placement of the tube. The tip of the tube should rest in mid-trachea, and there should be a low cuff pressure to reduce the risk of airway trauma. However, most of the cuff tubes that are available have an inappropriate design for pediatric use. Some have a very high cuff position, some have a very long cuff, and there are absent or unreliable depth marks present on the tube. And also there are no reliable size selection recommendations given. Therefore, we are not entirely unjustified when we say that the majority of pediatric anesthesiologists are still not convinced about the benefits of the use of cuff tube in pediatric anesthesia. With the advent of the microcuff tubes from the year 2004 onwards, these microcuff tubes are available. They are cuff tubes which have an ultra-thin polyurethane cuff, which is about 10 microns in thickness. And these tubes have high volume, low pressure cuff, and they offer excellent sealing. They are available in size 3 onwards. This thin cuff allows a uniform surface contact. The cuff is placed distally, and there is no Murphy's eye. There is ideal cuff placement because there is a intubation depth mark, and this allows for a cuff-free subglottic zone. And studies have shown that the average cuff pressure generated by these tubes is about 11 centimeters of water, which is much lower than that by cuffed endotracheal tubes. Coming to the a word here about the airway edema and airway resistance. Infant's lumen is already narrow. It's about 4 millimeters in diameter. Any compromise by edema, even a minimal edema of about 1 millimeter, will lead to a significant increase in the airway resistance and the work of breathing. Other differences: children have higher oxygen consumption and higher CO2 production as compared to adults, leading to a limited oxygen reserve. Their chest wall is more compliant, lungs are less compliant, they have a low FRC, and apnea and anesthesia further decrease the FRC. Therefore, they need IPPV during anesthesia and PEEP to prevent lung collapse, and CPAP is required during spontaneous ventilation to improve the oxygenation and decrease the work of breathing. Their tidal volume is relatively fixed because the horizontally placed ribs are unable to execute the bucket handle action as in adults. Therefore, the minute ventilation is largely dependent on their respiratory rate. The ventilation is primarily diaphragmatic, and any condition which will impair this, as in poor bag mass ventilation, will impair the ventilation. The muscles of ventilation are easy fatigable, and also the children are more sensitive to mechanical and chemical stimulation of the larynx, leading to laryngospasm. In premature infants, they are more prone to respiratory distress syndrome, and postoperative apneas are also common in premature infants. The physiological dead space is already high, it's about 30%, and by the use of ill-fitting and oversized anesthetic equipment, this can further be increased. So coming to difficult airway assessment and management. Now, what is a difficult airway? Difficult airway has been defined as a clinical situation in which a conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, difficulty with tracheal intubation, or both. So this is the difficult airway algorithm as given by the ASA task force in 2013. And our goals of airway assessment are, first of all, to identify and confirm the presence of difficult airway. Secondly, to assess the likelihood and clinical impact of 6 basic problems. We have to look if there is going to be difficulty with patient cooperation, if there is going to be difficulty with mask ventilation, difficulty with placement of the supraglottic airway, difficulty with laryngoscopy, difficulty with intubation, or difficulty with surgical airway access. Subsequently, an appropriate plan and backup plans have to be developed, and patient has to be prepared appropriately. So the pediatric airway has been classically classified into 3 categories. First is the anatomically or the physiologically normal airway. These are the patients who have a normal airway, and the differences are the predictable differences as already detailed. And here, with experience and training, even non-specialist pediatric anesthesiologists or occasional pediatric anesthesiologists can deal with the airway comfortably. Second category is the impaired normal. Here, the initially anatomically or physiologically normal airway, when it is affected by one of the acquired conditions such as any infection like a URI, allergic reactions, trauma, or foreign body, becomes impaired, and this may cause problems in airway management. The third category is a known abnormal airway, wherein patients with congenital anomalies such as Pierre-Robin syndrome, golden hour, Hunter, Down syndrome, etc., these present for surgeries, and these have already a predictable difficult airway. And these categories are under the domain of the experienced pediatric anesthesiologist. And one must remember that maintenance of spontaneous ventilation and use of an LMA is advisable in these patients. So pre-op assessment includes taking a detailed history. Majority patients are asymptomatic. One has to rule out any symptoms suggestive of an obstructive sleep apnea, any complications at birth or of previous surgery, airway surgeries, rule out any acquired condition that the patient has developed, if there's any difficulty in speaking, breathing, feeding, hoarseness, etc. Rule out if any other medical comorbidities and other congenital syndromes. Airway examination. Pediatric difficult airways are associated with dysmorphic features which are easy to recognize. So look for anomalies of the head, the face, the teeth, the tongue, the palate, the the mandible. Look for the complete range of motion of the jaw, the head and neck, and signs of airway obstruction. Always do take a baseline saturation at room air. Limited head extension, reduced mandibular space, and an increased tongue thickness. These are the most reliable predictors of difficult intubation. Lemon, it is a mnemonic for identifying adult patients with a difficult laryngoscopy, and though this has not been validated in pediatrics, but it can still be used with caution in older children. Congenital syndromes are associated with difficult airway, and it should be anticipated. And this is a list of congenital syndromes and their difficult airway predictors and the implication of these on the airway management. Now, how do we plan and prepare the airway management of a child? So one must follow a simple, intuitive, algorithmic-based approach. Make sure that all the equipment as required for suction, oxygen delivery, airway control, drugs, and monitoring equipment is available. Take an informed consent from the parents or the caregivers. Assign the responsibility to provide assistance to a trained individual. Pre-medication, avoid sedative pre-medication. One must always remember that administration of supplemental oxygen throughout the procedure is mandatory. So this is the suspected difficult airway algorithm as proposed by Boston, Massachusetts. And the first and the foremost point that has to be taken care of is whether the ventilation by face mask will be difficult or not. So if we expect that face mask ventilation will be difficult, then we have to look at other approaches, whether the awake sedated approach would be feasible for this patient. And then if it is, we'll follow this table on the left side. If ventilation by face mask is not expected to be difficult, then we can proceed with general anesthesia. General anesthesia either by inhalational induction or by IV induction. However, inhalational induction with preservation of spontaneous ventilation is preferred in children. So if bag mask ventilation is difficult as seen with inadequate chest expansion, abdo-distension, poor and tidal carbon dioxide concentration, falling saturation, look for the causes. There can be an anatomical cause or there can be a functional cause. An anatomical cause can be something as simple as inadequate head positioning. It can be a poor technique, a large adenoid, tonsils, foreign body in the airway, gastric content. Functional airway obstruction, it can be a laryngospasm or it can be an overinflated stomach. So it has the cause has to be identified and dealt with appropriately. One must do an appropriate sizing of the mask. This is the way the sizing of the mask is to be done. It should be a clear, transparent mask extending from the glabella to the chin. And to optimize the mask ventilation, the first step is to optimize the position of the patient. So optimize the jaw thrust, the chin lift, and the head tilt. If this does not work, one must consider the use of an oral or a nasal airway. Oral airway, again, the sizing is very important. It should extend from the tip of the incisors to the angle of the mandible. If it is oversized, it may push the epiglottis downwards, further impeding the, further causing airway obstruction. If it's small in size, it may kink the tongue and further cause airway obstruction. If one-hand ventilation is not appropriate, consider two-hand ventilation, either the EC technique with two hands or the VE technique with the two hands. The next step that we have to take care of is whether the child requires intubation. If the child requires intubation, then what would be the position for intubation, which we have already discussed. What is the next point is what is the technique for endotracheal intubation. So endotracheal intubation can be either fiber optic guided, video laryngoscopy guided, through direct laryngoscopy, through a supraglottic airway device, through retrograde intubation, or with the use of intubation aids. So direct laryngoscopy positioning we've already discussed. Choice of endotracheal tube we have already discussed. Choice of laryngoscope blade. For older children, curved Macintosh blade, wherein the blade, the tip of the blade is placed in the vallicula, is appropriate. But for smaller children, as already discussed, and for neonates, a straight blade, a Miller straight blade is recommended, wherein the tip of the blade is placed under the epiglottis and then it is lifted anteriorly to expose the vocal cords. Video laryngoscope. These are promising intubation devices with skills easy to obtain, and they improve the laryngeal visualization. They can be used either as a primary device or as a rescue backup device. There are a variety of video laryngoscopes available nowadays. Some of them are channeled and some of them are without a channel. The ones without a channel have an optical system and a viewing window, and the ones with the channel have a channel wherein a tube can be preloaded in the curved blade pre-hand. Then supraglottic airway devices, they have a unique place in pediatric airway management. One must choose the appropriate one according to the age, size, and the use for which it is mandated to be. They are relatively easy to insert. They can be used in the awake patient or after inhalational induction. They can be used as a primary device or a backup device for ventilation, intubation, or as a rescue device. A variety of supraglottic airway devices are available. First generation devices have an airway tube only. Second generation devices have additional features to reduce the aspiration risk. This is a table which shows us the various supraglottic devices which are available nowadays in pediatric sizes and the advantages and disadvantages of each. Some of the supraglottic airway devices can be also used for intubation, like the iGel and the AirQLMA. Coming to fiber optic guided intubation, fiberscope is a versatile equipment which provides a clear view of the airway as it is advanced towards the carina from the nose or the mouth. Techniques can be fiber optic guided oral intubation or fiber optic guided nasotracheal intubation. But one must remember that all these require a meticulous preparation of the patient, and one must ensure availability of trained assistants and appropriate equipment prior to conducting this procedure. This is a view of the flexible intubating fibroscope, and fibroscope intubation can also be done through the LMA. So a view of the difficult airway cart that one should have ready. We should have drawers containing equipment related to intubation, second drawer for oxygenation via supraglottic airway devices, third drawer for devices appropriate for face mask ventilation, and the fourth drawer for equipment related to establishing a surgical airway. In addition, flexible fiber optic fibroscope and adjuvant tools are required. These are the different airway devices that one should get ready for planning a difficult airway of a child. So just before I conclude, I'll briefly talk about this case. This was a 2.5 kg child who presented, female child who presented with a single swelling over the occiput and the upper neck region. And on airway examination, the child had micrognathia and a short neck, and the neck movements were greatly restricted. Malampati evaluation was not possible. The child was accepted under ASA2 with a difficult airway and was planned for excision and repair of the leaking occipital encephalocele. So according to the difficult airway algorithm, we assessed, we did the airway assessment. We identified the presence of the difficult airway. We found that there was going to be difficulty with patient cooperation. The patient was a neonate. There was going to be difficult mask ventilation, difficult supraglottic airway placement was expected, difficult laryngoscopy, difficult intubation, and difficult surgical airway access was also anticipated. We drew an appropriate plan for managing the airway of this child, and we did decide that endotracheal intubation was required for this patient. So, considering the merits and feasibility of the basic management choices, we planned intubation after induction of general anesthesia, using the non-invasive technique as the initial approach, using the video-assisted laryngoscopy as the initial approach, and with preservation of the spontaneous ventilation. Our plan A was use of a video laryngoscope, assisted intubation with a stiletted size 3 tubes, using a Miller 0 plate. Plan B was insertion of a supraglottic airway in case plan A failed, followed by intubation with an endotracheal tube preloaded on a fibroscope, and plan C was establishment of a surgical airway. Had we landed in the cannot intubate, cannot ventilate situation, our primary plan was to secure the airway with a supraglottic airway device, IGEL size 1. An alternative plan was to have an emergency airway access. Our strategy for extubation was awake extubation, as better control of the airway was expected at extubation once the occipital swelling was removed. After adequate planning and pre-op preparation, which included getting the airway cart ready, we had assorted small size face masks were kept ready, and oral airways, nasopharyngeal airways, and tracheal tubes of various sizes, endotracheal stillets, supraglottic airways of rigid laryngoscope with appropriate size small Miller blades, rigid laryngoscope with small size Macintosh blades, with small size Miller blades. Fiber optic bronchoscope was not ready. The monitoring was established. Patient was started on fluids. Pre-oxygenation with 100% oxygen with face mask was done. Pre-medication was instituted. This was followed by inhalational induction using sevoflurane in increments from 1 to 6% and 100%. Patient was kept on spontaneous ventilation. Initially, a single hand technique was tried. Since it was inadequate, the head position was adjusted, the chin lift was adjusted, and a two-hand technique was used. And the ventilation subsequently became adequate. When an adequate depth was achieved, a video laryngoscopy with size 0 Miller blade was attempted, and the modified CL view grade 3 improved to 2B once OELM was applied, and a stillated endotracheal tube was introduced into the trachea. The rest of the course of anesthesia was uneventful, and the patient was extubated awake. So the take-home message is that safe and effective airway management in children requires an understanding of the fundamental concepts and appropriate use of available resources and locally adapted algorithms. Includes maintenance and preservation of spontaneous ventilation is the sine qua non of difficult airway management in infants and children. Difficult airway recognition, preparation, and familiarity with backup plans for airway management is essential. Thank you, and greetings from my institute.
Thank you, Poonam. It was a lovely presentation, theoretical as well as practical presentation also we got. All of us know the smaller the baby, the more are the technical difficulties and the less is the reserve. So all the postgraduates should know that they should have the theoretical knowledge, and age-appropriate equipment is the key sentence for the difficult airway for children. Otherwise, even if you know the sequence of algorithm, you cannot achieve anything. Very nice. We will be dealing with the questions at the end of the talk. Thank you. Over to Dr. Usha, ma'am. Next speaker, Dr. Sapna.
Good evening, ma'am. Dr. Poonam need to stop sharing the screen.
Okay,
that I can share my screen.
Just a second. Sorry.
और ये प्याज
Okay.
2 किलो 50 देसी घी.
I think there is quite a lot of distance.
आधा किलो दे ना 20 रुपए कहाँ तो है 50 का पाव तो ये कैसे दे रहे हो 20 रुपए का आधी किलो आ रही 20 रुपए बोला भी तो तुमने 20 रुपए बोला है.
Did you screen
See, last session, last lecture, Dr.
Dr. Sapna Bathla. She's an associate professor in anesthesia at DMMC and Safdarjung Hospital. And she's going to speak on a very important topic in pediatric anesthesia. And this is the upper respiratory tract infection, what decision to do, when to do surgical anesthesia or not, difficult IV access, another important problem, laryngoscopy and spasm, laryngospasm, unexpected hemodynamic disturbances in the form of severe hypotension, and emergence delirium, which we are all worried about. Dr. Sapna Bathla, please continue. Please.
Thank you so much, ma'am, for a nice introduction. Good evening, everyone. So this is an important topic and the last topic of the evening today. I request everyone to mute their mic, please. So this is important topic, and this evening we have talked about a very special population, that is a pediatric one, who have the unique needs and also the different challenges. So let us see what all perioperative challenges we see and manage in the pediatric practice. So we know there are many challenges. Of course, there are many challenges when we manage the pediatric patients in OR. But for the sake of discussion, we have picked few. For the next 20 minutes, we'll be discussing them. So coming to the first challenge, that is upper respiratory tract infection, that is URTI. I think every one of us who have practiced pediatric anesthesia must have faced this challenge in our ORs. So this is actually a matter of debate, as Dr. Usha ma'am rightly said, for many years now, whether to proceed with the elective surgery or no in a child with a URTI. Now, why are we in dilemma over this issue? Because on the one hand, the safety of the child is important. On the other hand, if we do cancel the case, it puts a lot of emotional and economic burden on the parents as well as on the health sector. Fear of litigation is always there. So what all questions comes to your mind when you take up a child with a URI? The child has a common cold. Now, should his or her surgery be cancelled? If yes, for how long? Why are we worried about cancellation? Can we explain all the respiratory events to the parents? And if we decide to take up the patient, how it is going to affect our anesthesia, and what should we do to smoothen our course? Now, if we just look at the data, approximately 25 to 45% of the children present with a URTI who are coming to us for elective surgery. And each child, approximately, these children have 6 to 10 episodes of URTI in a year. So if we wait for 4 to 6 weeks in each child for each episode, we hardly find any time when they are totally fit in a year. It means that they give a very small window period. Now, let's see how the URTI is being defined. So there is no clear-cut definition. In fact, it is a constellation of the symptoms, starting from scratchy throat, malaise, sneezing, rhinorrhea, congestion, and so on. So to make a diagnosis of URI, 2 of any of the above sign or symptoms are required. Now, why are we worried about the URTI? Because when we take up the child with a upper respiratory tract infection, we are bothered about the perioperative respiratory adverse events. And what are they? They can be anything from laryngospasm, bronchospasm, breath holding, desaturation, etc. Now, there are various, can we predict the risk for the adverse respiratory events? Yes, of course, to a bit. By Pernis et al., they have said they are the patient-related factors, anesthesia-related factors, and surgical factors which need to be considered while taking up the decision of this patient. Now, this is a score. This is cold score. This is scoring for assessing the risk in a child with an upper respiratory tract infection. Here we have 5 components and the score of 1, 2, and 5. Any category having the 5 score of 5 is taken as a red flag. Now, if the child has a common cold, should the surgery be cancelled? Now, taking this decision, we need to consider many factors like what is the child's age, what are the symptoms, type of surgery, need of the endotracheal tube, and of course, anesthetist comfort and experience also matters. So for this sake, the children are divided into 3 groups. The children with the systemic symptoms like fever, malaise, etc., And with the LRTI signs, definitely must be postponed if it is an elective, unless until it is an emergency. If it is a mild URI without any systemic symptoms, we can definitely go ahead. Mild URI is postponed only if there are certain risk factors and the predictors. Now, cancellation for how long? Again, a very important question. No RCTs regarding the best timing of GA in children with URTI. But of course, the children should be, we need to wait for at least 2 weeks. Now, what is a preoperative care? There is no standardization. Of course, the practice that is being done everywhere is referring the rescheduled patients who have the systemic symptoms and with the LRTI to a pediatrician for the further assessment and treatment. But of course, for the patients who are proceeded with anesthesia, preoperative nebulization with the salbutamol, corticosteroids, and chest physiotherapy are commonly prescribed. Anticholinergics are still a matter of debate, plus and minus. Now, this is a guide to the algorithm to manage a child with a URTI. So, supposedly a child with a URI, to optimize the child's condition with adequate hydration, humidification, suctioning, and bronchodilators. Proceed with GA. Use a minimum invasive airway device depending upon the surgical requirements. LMA versus endotracheal tube. And at the end of the surgery, do the clear suctioning of the oropharyngeal secretions. Now, removal is either awake or deep, depending upon your comfort and, of course, your PACU. Your PACU, how far it is, how well monitored it is, how well staffed it is. So, remove the LMA or endotracheal tube. Now, so to manage these childs, if we are taking up the cases to manage this child, we proceed with the inhaled salbutamol, alpha-2 receptor agonist as a pre-medication if required, induction with IV agents such as propofol, maintenance with the inhalational agents such as sevoflurane, use the least invasive airway device, preferably face mask over LMA over ETT, administer IV lidocaine or propofol before manipulating the airway, remove the device with the child deeply anesthetized, provided your conditions are not compromised. Experienced pediatric anesthesiologists should manage the child's care, aggressively treat bronchospasm if it is, deliver the supplementary oxygen to patients during the transport and in PACU, and careful monitoring of the SpO2 and other parameters in PACU. So to summarize, in this URI, there's a lot of good judgment, common sense, your experience, informed consent, of course, and everything needs to be documented. All these things makes a lot of difference, and judiciously you need to decide whether to go ahead with a URI or no. Now, the second entity that we are going to, the second challenge rather, I should say, in the pediatric practice, important, we are going to discuss is a laryngospasm. This is, we all know that this is a prolonged aortic closure due to the constriction of the laryngeal muscles. This is a protective reflex and protects the trachea from aspiration. This can be either complete or partial. Complete, we can identify by looking at this. This is a silent chest. There's no bag movement and no ventilation is possible. This is an emergency, actually. And partial laryngospasm, when there's some chest movement is there, but a stridulous noise is there. And there's a mismatch between the respiratory efforts and the bag movements. Now, mechanism, we know that this is because of the internal branch of the superior laryngeal nerve stimulation. The signs you can pick up early also, and sometimes you get late, you are not able to pick up, and earlier there's a tracheal jerk, paradoxical movement, and respiratory features of respiratory distress. But if you do not pick up at this stage, patient might desaturate, go into bradycardia and the cyanosis. Now, again, the risk factors are similar. We can categorize into anesthesia related, like airway manipulation, a lot of airway manipulation, if inadequate plane of anesthesia, suctioning, etc. Patient-related factors, if there is a history of prematurity, if there is a history of smoking, snoring, or any passive smoke history. Surgery-related, it is airway-related surgery, and experience of the anesthesiologist, I said, it's matter a lot. Occurrence, it is mainly seen during the induction and the emergence of anesthesia. And so Vishwanathan et al. Found that the incidence of laryngospasm occur more during the induction phase if the patient is on LMA, and high during the emergence phase is if the patient is on endotracheal tube. Now, how to prevent this entity? The lidocaine 1 to 2 milligram per kg, or topical or IV, administered within the 5 minutes before the extubation. Magnesium sulfate 15 to 30 milligram per kg 2 minutes after intubation, or you can use subhypnotic dose of the propofol, that is 0.5 milligram per kg before extubation. Now, treatment, if this do happen, then how do we need to treat? Then this is a physical method divided into physical and pharmacological method. Under the straight away, we need not to jump on the succinylcholine unless until it is indicated. So CPAP delivered by face mask with 100% oxygen is the first treatment modality to be tried. Another is a Larson's maneuver, where we give a pressure in the laryngospasm notch, and this is given for 3 to 5 seconds, initially bilaterally. And this makes it, gives a lot of pain to the child, and child tries to cry and breaks the laryngospasm. Then amongst the pharmacological methods, you deepen the plane of anesthesia by giving additional propofol. If hypoxemia is occurring, then the treatment of choice is definitely an immediate neuromuscular blockade with the succinylcholine. Low dose succinylcholine here is quite effective in treating. We can see that such a low dose can be given for the breaking of the laryngospasm. Some pediatric anesthesiologists do prefer co-administering the anticholinergic agent. If, God forbid, we do not have an IV access and we land up into this kind of crisis, definitely succinylcholine can be given by the IM route, and the route dose is different. Now, the third entity is unexplained hypotension. Now, before we go about hypotension, we need to know a little bit of introduction, that we know that the tissues depend upon the oxygen supply and thus on the perfusion. So certain minimum amount of blood pressure is necessary to guarantee the perfusion. And the blood pressure is the most important parameter that we can practically do, and we practically do as a surrogate parameter for the perfusion. Now, hypotension, if it is of the prolonged duration, it can be associated with the serious consequences. Initially, it was a history when the no BP measurement was done in the shorter cases in the children, but it is no more a practice. It has now become a standard of care. It is blood pressure should be done, a measurement should be done in each and every case in a child. Now, when we talk about intraoperative hypotension, the most important question comes, what minimum blood pressure is acceptable in what age group, and which parameter to be used, either it is mean or it is systolic. Now, there is a lot of variability. If we when we did the literature search for this, over all the review articles, everything, and the textbooks, we could find that there's a great variability in the blood pressure measure parameters and the threshold among the pediatric anesthesiologists. Most of the pediatric guidelines, they define hypotension in the terms of systolic blood pressure and not the mean blood pressure. And they say that it is more than 20 to 30% decrease on the systolic blood pressure from the baseline, and or below the 5th percentile of the, as per the age. So this is how the intraoperative hypotension is defined. We do see that in everyday anesthesia practice, we are also more comfortable looking at the systolic blood pressure more often than the MAP. And this was confirmed in the survey by NAFU et al. But we know, on the other hand, we know that the mean arterial pressure is a major determinant of the tissue perfusion pressure. So we must also be knowing the target mean arterial pressure in each age group. And thus the mean arterial pressure should also be monitored in the critically ill children for the resuscitation purpose. But this MAP is actually a derived value. So if we look at the normal pressures as per the age, we know that newborns is 60, 1 year up to 1 year is 70, 1 to 10 years it's 70 plus 2 into age, and more than 10 years it is 90. Now, target MAP, which is actually your target to maintain the tissue perfusion, is in preterm, it is almost corresponding to the gestational age. For the term newborn, it should be more than 40. Smaller children, more than 50, and school children is more than 60. So anything reading beyond, below this needs to be treated. Now, what all can cause intraoperative hypotension? The question is this. So in the children, it is most commonly the hypovolemia, that is the relative volume deficiency. The anesthetic drugs can also be the culprit because intraoperative hypotension in children is generally seen after the induction. It can be the surgical blood loss, it can be any concomitant disease or the mechanical ventilation, and rarely the regional anesthesia. So how do we know, besides the blood pressure measurement, there is a patient presents with tachycardia, which is again very non-specific because tachycardia is seen in many of the other features. We can see the cold distal extremities, weak pulses, delayed capillary refill time, and decreased urine output besides others. Now treat. How do we treat? We rule out the other causes and address them. Decrease the inspired concentration of the inhaled anesthetic. Prefer restoring the euvolemia rather than straight away jumping to administering the pressors. For restoring the euvolemia, where my colleague Dr. Geeta Setia has already wonderfully covered the pediatric fluid, but of course this is a crisis situation, hypotension. So we start with a balanced salt solution such as eringal lactate in the bolus dose of 10 to 20 ml per kg. We can repeat twice or thrice at least. Replacement of blood loss, if any. Apart from the fluid supply, if at all after these interventions, still the blood pressure is below the normal limit, and we need to, the children might need vasoactive substances as well. Now, the selection, which drug to be used, is often determined with the personal experience and the established local practices. Bolus injection of 0.1 milligram per kg body weight ephedrine IV produces very small and transient effect as per the gas study, which is a recent one. Now, the choice of drug. Let us see how do we select the drug. The commonly used vasoactive agents in the pediatrics are the same as we use in the adult population, but here the selection of the appropriate agent depends upon the patient's presentation. The current pediatric guidelines, septic shock guidelines, they recommend that starting with a vasoactive agent with the inotropic properties, the agents which have the vasoactive with inotropic properties such as the dopamine or epinephrine in the higher doses, given the preponderance. Why? Because it is more of a cold shock in children rather than the warm shock. But supposedly the children comes in the warm shock, the vasopressor agent such as the norepinephrine becomes more appropriate agent. But of course, often children have a dynamic shift. So it is not necessary that we need, the patient is in one hydrodynamic state, so we need to stick to one agent. It can be shifted from to another state. So the constant clinical monitoring and the changes in the agent might be necessary. So regardless, if at all you are not able to identify the choice of agent, you are not able to identify the physiology. So still in that case, and you are in hurry, if you want to give some support, the peripheral inotropic support with epinephrine has been shown to be quite safe for the shorter durations and should be started immediately in the patients with a fluid refractory shock until you obtain the central venous access. Now coming to the fourth challenge, it is a difficult venous access. This is, I think, we all are very familiar to this kind of scene in the pediatric ORs. Everybody is picking up one limb and trying the cannulation, and one is on the head end. So this is what we want to avoid. So this is cannulation is a basic skill. It is the C part of the ABC needed for everything, starting from anesthesia, resuscitation, medication, fluids. It's a big challenge. Why it is difficult in pediatric? Important is the vessels are very small size, they are mobile, they have a excess fat, subcutaneous fat. Pediatric patients are less cooperative, they withdraw, we see the withdrawal, and so the cannulas, whatever we put, have a shorter life, and we need to take a repeated attempt, and so the sites gets exhausted. So these all things make it difficult. Now, what is actually DIVA? DIVA is difficult intravenous access. So when do we label intravenous access as difficult? When your IV requires more than one attempt and special interventions are either anticipated or required. When do we label it as attempt? Anything whenever you penetrate a skin with or without flashback is considered as an attempt. Now, if we do a look at the figures, which we might not be knowing, the first attempt success rate of the IV in OR is 70 to 80%, which is quite good, but in wards, it is even still lesser. First attempt success rate, if we split into the age-wise, in neonates, it is only 53.5%. Mean time taken up for the successful attempt is around 140 seconds, and child requires, on an average, 2.2 attempts. Now, if we look at factors, what all factors do predict the difficulty in intravenous access, there are three key factors besides others. The vein palpability, whether it is palpable or no, whether it is visible or no, and what is the age of the child. Besides that, we all know there are other factors like illness factors. We do see that the child who are dehydrated, we do keep struggling with the IV cannulation. If the child is obese, similarly, if the patient is of some chronic illness and on some chronic medications. So all these things decide whether this is difficult or no. So score is there to assess the difficulty of the intravenous cannulation. So this is DIVA score, visible vein, palpable vein, and age, 0, 1, and 2 points. If any score, which is 4 or even more, increases, that there is more than 50% chances of the failed initial attempt. I've given the references simultaneously with the slides. You can see So if at all, now after the prediction, if we do come across such a challenge that our IV access is difficult, what all do we need to do? How do we need to prepare? And how should we go about it? So we need to reassure the child by the parental presence. We can pacify the child with a pacifier. If you have Embla cream at your place, you can apply that quite well in time before the IV cannulation attempt is taken. In the intra-op, we do see that generally we do keep only one size of cannula and we start with IV cannulation. This should not be so. My humble request to the postgraduates who are in the training phase that please do prepare and then start the attempting. So keep IV cannulas of the various sizes at handy. Central venous cannulas and intraosseous needle and whatever devices you have, keep handy. You do not know when you will be stuck, and especially if your DIVA score predicts the difficulty. Now, DIVA tips and tricks. The important first point is be calm and be confident. Whatever you are going to do, maintain your calm and be confident. Explain the procedure properly. Select a suitable site. Tourniquet. Form the limb. This actually helps. Attempts the sides, distal sides first. Do not take the proximal sides first and, create your problem for your own. Maintain a narrow angle. I'll show you this in picture, how much angle is needed. Go proximal to an exhausted vein. Consider splinting. This is very important. We do take a cannula, then we just forget splinting. We start with our procedure and 10 minutes later, we see that the cannula is out. And again, we are at the same point where we started. And flush the cannula and secure with a clear adhesive. Don't use Dynaplast for the pediatric IV cannulations. Make it clear and transparent so that you can see the distal end. Now, this is technique. How do you hold a child, infant's hand? How you go at a shallow angle of insertion, and how do you fix it with a tegaderm nicely and flush it. Now, this is troubleshooting. You can see one first child. Here we could get the IV cannulation easily. And this is another child where the difficulty is expected, and awake IV seems to be a little difficult. So we went for the inhalational induction. Now, this is actually an algorithm. This shows that if your case is elective, then you can try with the forearm veins, 2 attempts on each side. If it is not successful, you can, of course, try another sides, alternative sides, that is the lower limbs. You can ask for expert help, or you can consider adjunctive measures like ultrasound and vein viewing devices. But if it is an emergency, you start with the antecubital vein and 2 attempts on each side. Do not attempt other sides. Ask for external help, additional help or expert help, and consider central venous access or intraosseous, whatever you are comfortable and you are having handy. Now, choosing a catheter size, there's charts available which shows what size catheter to be used and what length to be used for different central venous cannulations. This is a various intraosseous lengths and sizes for the different age group. This is 3 to 40 kg, more than 40 kg, and this is like this. Now, technology has progressed, and we have now ultrasonography at our hand, and of course, the many vein viewing devices in which we have near infrared technology. That is, in this, the deoxygenated hemoglobin absorbs the infrared, and this is devices vein finder and trans illumination device also used below less than 2 years. This is ultrasound guidance. This, of course, has a certain amount of learning curve is there, but once you learn it, it of course reduces your time and makes the things easier. These are the vein viewing devices. This is how it affects, and there are 2 technologies, the trans illumination and near infrared light devices. Now, the take-home message for this challenge is the first chance is always a golden chance. So I put a lot of stress on becoming confident and after the adequate preparation, so that you do not miss a first chance. Keep your muscular access. If this is an elective case, escalate the help after 2 attempts. Resort to USG and other devices you have, and consider intraosseous access and CVP line for emergency scenarios. Now, coming to the 5th challenge, this is emergence delirium. This, I think, is also a pediatric anesthesiologist. Those who practice pediatric cases must have seen. This is a state of dissociation. Child keeps crying, agitated, excited, and this generally seen after the awakening from general anesthesia. This is seen approximately in 10 to 30% of all the children in PACU. The duration is short. So hence we do not treat much, and might be we must not have given a lot of, consideration over this. attention to this because it generally resolves spontaneously, but it can continue for up to an hour. Before we reach to the diagnosis of the emergence delirium, we need to rule out the many other causes which can be the reason for the agitation in a child in PACU. And the most common is the pain. Many scoring systems are available for the assessment of the patient in emergence delirium. The most common and reliable and validated tool is PEAT scale. The others are Crivero and Vacha. Vacha scale is generally being used because it is convenient in our whatever studies we do. This is PEAT scale. This has 5 components, and again the scoring from 1 to 4. Now, the risk factors, who all patients can develop this emergence delirium. This depends again on the patient, surgery, and anesthesia. Amongst the patients, this is more common in the preschool age children, 3 to 6 years, and even in the very small children, less than 3 years is the most common age. Now, if the child is already anxious, already temperamental, if the parents are anxious, this is also very important factor, preoperative risk factor. The surgery, it is more common seen in the ophthalmic and ENT surgery. And under anesthesia, if we see, this is more common with the volatile anesthetic agents, that is with the sevoflurane, and emergence duration also matters a lot. That is, if the child is coming very fast out of anesthesia. Postoperative pain has been linked, but there is no consensus regarding this. Now, clinical presentation. Besides this, we have already talked about, there can be some maladaptive behavior also, which we can see in the post-op. That is, the child can have a sleep disturbance, bedwetting. He might then throw tantrums. He can be an attention-seeking and feeling lonely. Now, this prevention can be non-pharmacological and pharmacological both. From non-pharmacological, there is an advanced strategy. This is an acronym, and here we can use different methodology. You can show the videos, you can distract the child, add on the parents, you can reduce anxiety, and so on. Prevention pharmacological, propofol can be given at the end of the surgery to prevent this. Intraoperative fentanyl helps a lot. Ketamine, clonidine, dexmedetomidine. Preoperative gabapentin in magnesium infusion. This I have completed the list, of course, the entire list, what all can be used. But of course, my personal experiences with propofol and fentanyl, and of course, nowadays with dexmedetomidine. We can still complete this list by adding the melatonin, which is being used these days. Now, why are we bothered about emergence delirium? If it is so short-lasting, if it is spontaneously resolving, we might not need any treatment. We might need only prevention. But why we are bothered, why this is a challenge, why we are discussing here is because we really need to be very watchful for the dressings, for the IV line, which might be precious in the patient. And child can self-harm. So here this is very, very important and becomes a challenge. The parents should always be included in the treatment decision whenever possible, and whenever it is terminated, the recurrence has not been reported. So the management is, how do we manage? Supposedly we need to manage is by pharmacological. The sequence is the correct diagnosis. First of all, treat pain. The patient should be absolutely pain-free. Then only you can reach the diagnosis of emergence delirium. Rule out the other organic causes. It can be a full bladder, it can be a restraint, anything. So, or rule out all those causes, assess the severity, whether you need treatment or no. Parental presence, promote the parental presence. And if at all, generally parents do not want any treatment, but if at all you feel like it is important, it is necessary, give the subhypnotic doses of the sub-anesthetic doses by the trained personnel. Thank you so much for your kind patience. Thank you.
Thank you, Dr. Sapna. You very well spoken on all the 4 topics, all the 5 topics, which are very, very relevant to the anesthetist. I would just like to say one thing, a few things, just one comment on each. Hypotension, first of all, we must try to avoid all these problems, because if things go out of hand, then it is a catastrophe. And preoperative evaluation and preoperative preparation goes a long way in preventing these complications. Number 2, hypotension, most of the time it is because of the low volume, intravascular volume. So the first management point is giving adequate fluids and preventing it, and then go on to the drugs that are required. And in case the drugs are required, we must look seriously into something else which might be present, because otherwise, generally, the IV fluid we would be able to manage with IV fluids. Now, IV line, yes, you get the same happiness on your face when you place an IV line in a baby who is fat and chubby or very small the same success, that you get with placement of an endotracheal tube. And everybody must remember, IV line is the basis of anesthesia. You cannot proceed beyond it till you place an IV line. I remember once we had a very, very difficult child, and it took us almost half an hour, 45 minutes, including the surgeons doing it. And then finally one on the scalp was put and we proceeded with the surgery. And emergence delirium, yes, it is an emerging problem. We have never bothered about it in children. And the importance is that they're not able to project or tell, and neither are we able to understand. And the impact comes much later in life, maybe at the teenage. And at that time, nobody correlates it with a childhood event, So now there's enough literature which says that adverse experiences in the childhood, earlier in the childhood, they have an impact later on in the psychological development of the child. So it is very important that we take care to prevent emergence delirium rather than reaching a situation of treating it. And if a child is able to understand preoperative preparation and counseling and telling the child what all is going to happen can help a lot, along with the presence of the parents or the caretaker, whoever the child is comfortable with. Thank you very much, Dr. Sapna.
Thank you so much, ma'am, for your wonderful inputs and sharing your experience. Thank you so much. Actually, it was really tough to cover 5 topics in 20 minutes.
But you've done it very well, Sapna. Hats off. Congrats.
We gave the whole package to you, but that was all very important. And you did a really good justice.
Thank you.
So let's see if there are some questions in the chat box. Deepanjali, let's see.
There is a question for Geeta. Geeta, are you there?
Yes, ma'am.
Can you use Berry's formula for fluid replacement intraoperatively?
Ma'am, for regular maintenance fluid replacement, we don't need Berry's formula to be transfused.
Actually, Frederick Berry's had just simplified a very nice formula, and that applies to the kids who have followed the NPO guidelines of clear fluids up to 2 hours. So it's very easy to remember for short cases, 15 ml per kg more than 3 years, and 25 ml per kg. And so for less than 3 years. So actually, you don't really have to calculate for a duration of 45 minutes. You don't have to calculate the deficit, the hourly requirement. So that really helps balance salt solution. Somebody was asking this. This was in the chat box. Okay.
Yeah. Ma'am, is this available? This formula, I read about it, but then I didn't add it, ma'am, because the availability is.
It is available.
Okay.
In fact, he had come to Lady Hardinge Medical College once to lecture. I was there. Dr. Dilip Power had arranged it. Okay. Another thing, one question for Geeta.
Yes,
how is hyponatremia is so significant for the children? I thought somebody will ask students, but nobody asked, so I just asked. Why we talk about hyponatremia for pediatric age group? Why not adults?
Because, ma'am, as I spoke earlier, also children's renal system is not capable of manipulating the electrolyte absorption and excretion as per the electrolyte imbalances as the adult kidney does. So that is the reason they would not be able to cope up with the sodium loss, because their sodium reabsorption capacity is already reduced.
Okay.
That is why this is very significant in children.
Actually, the children are prone for hyponatremic encephalopathy at a higher level of sodium, not as in adults, number one. And number two, when you give a higher volume of fluid, when the sodium comes down less than 130 in a short duration, they go into the rigid cranium and the intracerebral water, the accumulation leads to
cerebral edema. Yes,
cerebral edema. And the symptoms are very subtle. You cannot know unless you do a biochemical analysis. So that is why the isolite P is out of the OT nowadays. Low sodium. Okay.
And this is one reason also for emergency delirium. We don't know, and the child behaves very inappropriately, and we do not place the importance to the electrolytes and fluids. So that also should be investigated in patient with emergency delirium. Then there is something on propofol, Dr. Anju, TIVA. Do we use propofol in infants and neonates? We are using in adults, we are using in children. So somebody wants to know whether we use them in neonates and infants. Dr. Anju, are you there? She's left.
Yes.
Anju, yeah.
Sorry. Yeah, propofol can be used in infants, definitely. I've already given you the formulas and the different manual infusions that have been recommended for the age groups of less than 3 and even in neonates. But one should be careful when using propofol in neonates, but it can be used.
I think it should not be repeated. It can be used once. Isn't it now, Anju?
I haven't come across anything that says that. In a sick neonate, one should perhaps not use it, but I have not. The bolus recommended in neonates in the Stewart formula is as high as 5 milligram per kg, which I would be scared to give to a neonate. But it is not that it is contraindicated. You have to assess the child and you have to. But if the question is, can it be given? Yes, it can be given cautiously to the healthy neonate.
But propofol is still not approved by the FDA to be used in neonates. So, but still people are using, in NICU also they are using for sedation. But like Anju says, you have to be really very, very careful. And doses, though the requirement may be high, but you have to be very careful. I have not used in neonates. I'm scared of using propofol in neonates because of its milky nature going into that fine vein. I'm scared to put that mixture into that. I've never used it myself, but I know people are using and without any much consequences.
Yeah, I think many of us are not comfortable with using propofol in neonates, but it can be used in the healthy neonate, yes, but in a sick child coming for, laparotomy or something, I would also not use propofol. I would rather go for thiopentone for induction in that child. But it can be used if one is healthy, in a healthy child.
Okay. Then we have, yes, we use it only if there's contraindication. And another question, remifentanil is not available. Then what analgesic dose is being practiced?
As I described in my talk, various adjuvants can be used. We have dexmedetomidine, which is available. That has good analgesic properties. Fentanyl can be used. Ketamine can be used. So it depends entirely on the type of surgery that you're getting done. If it's a small surgery, I would give a small dose, analgesic dose of ketamine along with the propofol infusion. And that works beautifully. Just one single bolus can be given. If it's a long surgery, one could use even 2 of these adjuvants. Like a spinal surgery, I've got a couple of spines done for neurophysiological monitoring where I've used a very low dose of ketamine and a very low dose of dexmed. Because ketamine balances the hemodynamics of propofol very beautifully. So it's not, so you have to see the whole cocktail that you're giving to the patient. You have to see the patient's basal vitals, his heart rate, his blood pressure. If you use propofol and dexmed, you get a bradycardia and more of a hypotension, which is not desirable always. So ketamine is a beautiful drug. It balances the hemodynamics of propofol better. So depending on the surgical stimulus, depending upon the age of the patient, depending upon the how sick the patient is, what is his ASA status, you could use fentanyl for analgesia, you could use a regional nerve block, you could use dexmed, you could use ketamine. I know remifentanil is not available, so these are the options that we have to provide analgesia to children undergoing TIVA.
Yeah, remember anesthesia is such a wide branch. There is nothing absolutely do or don't do. And you have so many other options available nowadays that you can use. We also have I have never used remifentanil, but that doesn't mean we will not use analgesia in small children. So like we have used when we were postgraduates, even fentanyl was not there. So we have used morphine in neonates. We have used pethidine in neonates. So it depends on whatever drug is available, whatever technique is available. You study that, have the knowledge, and use it to the best of the capability with the best outcome in mind.
Yes, use a familiar drug which you're comfortable.
Yes.
That is why I wrote one indication for TIVA is that you can practice it. Your practice makes perfect. And many of us are not practicing it. So you have to play around and make a beautiful cocktail so that your child comes out very beautifully. And that can be a cocktail of multiple drugs. Each will decrease the dose of each and you get a nice outcome.
Okay.
Absolutely.
Can we use low dose ketamine for preventing post-operative emergence? Dr. Sapna.
I've already answered, ma'am, on the chats.
You answered?
But yeah. I have answered all the questions pertaining to my talk. That yes, of course, it can be used in a low dose for the prevention.
She has answered.
Okay. Differences between emergence agitation and emergence delirium.
This is a tricky question, ma'am. Because when I read the text, many of the articles, in fact, they use interchangeably. Though it is not, one is an umbrella and the other one comes under the umbrella. But still, because the features, the presentation are almost very much similar. Yeah. But emergence delirium is a term when we use it only after explorative, when we recover from the child comes out of the anesthesia. Emergence delirium. So emergence agitation, they are being interchangeably used, but of course they are not. So this I've already answered. But again, there's some confusion. We really need to look into that.
No, actually, I'm Dr. Anita Malik.
Yeah, ma'am.
Actually, agitation is a part of post-operative emergency delirium because those cognitive and behavioral aspects, they are there in delirium if it has to be counted, and PAED scale, PEAT scale is applicable. But because this is a very gross scale, so people are not using it. People are using Vacha scale. Vacha is actually the agitation scale. 5.1, and it's more convenient, and most of our problems like pain and separation from the parents, so many things which are included in the our anesthetic practice, they can be governed by these Vacha scale. So it's very convenient, but in actual sense, delirium is only applicable to the third or fourth scale or point of the Carvero scale and the fourth scale of the Vacha scale, which is the severely agitated. So agitation is a part of delirium.
Thank you.
Yeah, this is what I got through the literature. So
thank you so much, ma'am. Thank you.
Yes, thank you, Dr. Anita, for clarifying. I think there are no more questions in the chat box. Deepanjali, are there?
No, ma'am. That's okay.
Okay, so shall we wind up? I think all the 4 speakers have done a wonderful job. And thank you, all of you. Dr. Jayshree Sood, please take over now. Thank you.
Thank you very much. And thanks a lot, Usha and Deepa, for moderating such a lovely session. And we are so happy, the ICA is so happy that this webinar went off so well. The number of compliments and the lovely interaction speaks of the standard of the lectures that were there. Everyone, all the 4 speakers, Geeta, Anju, Poonam and Sapna have given their lectures so well. I can call you by your first names. You're so junior to me. And thank you very much. All the topics were so well covered, and truly speaking, the students actually come and tell us, ma'am, this question was actually asked in the examination. So this was, of course, theoretical part was very good, but the clinical applications which you all spoke was so good. Thank you so much. And thanks a lot. And we hope to see you in our further webinars. Thank you very much, and good night. And thank you, Rahul, once again for helping us out. And Saneesh and Rakesh, thanks a lot for hosting it.
Thank you, ma'am.
Thanks a lot. Thank you. Good night, everybody. Bye-bye.
Bye. Good night. Bye.
Thank you.